We're going to start our next skit as our actor and actress comes up to the stage area. Jerry, did you want to jump in, or shall I just?
Please.
Oh, okay. Okay, very good. What we'll do is we'll have the skit, we'll have more talk story, we'll also have our doctors, our panelists come up and also take questions, answers. But for those of you that are watching online right now, just like the last time, keep those questions coming. We love answering them, or if not, then we will follow up and leave us your contact information or direct message the hosts, and then that way we can get to you at a better time. Here we go. As Jerry discussed, we have two scenarios today. The second scenario is based on a more advanced Parkinson's situation. It is written and directed by Alex Munro, and what I'd like to do is that Alex is probably nearby. Alex, where are you? Wait, sorry, right there. Ladies and gentlemen, Alex Munro, there we go, raising his hand in the back area. Those of you on camera, there he is. Paul is being performed by Matthew Kelty. Matthew. Eleanor is being performed by Christine Lambourne. So I will go ahead and set the scene for you. Some background to the scene. Paul and Eleanor are an average couple. They have been married a little over 30 plus years. They have two grown children not living at home. They made decent money and were looking forward to enjoying retirement. They were even thinking about retiring to the 9th island. Paul is in his early 60s, diagnosed 8 years ago in mid-50s. Is nearing the end of a good career in the hospitality industry where he spent the last 10 years as a supervisor. His job as a supervisor and company disabled accommodation policies allowed him to continue working. Doesn't smoke, drinks alcohol on special occasions, eats fairly healthy meals. Eleanor, early 60s, also nearing the end of a successful career as a CPA. Doesn't smoke, drinks alcohol at social events or levels, eats fairly healthy meals. Paul recently started seeing things that weren't there. Watch.
I saw a cat yesterday. The guys and I were having lunch at this place that's been really great about accommodating my needs. And all of a sudden, this cat jumped up on the table and started cleaning itself. Nearly flipped my plate. The guys seemed startled too. And Chris asked, "Was that your Parkinson's?" I laughed. "My Parkinson's? No, I just wasn't expecting a cat to jump up on our table." And then the guys grew silent as I reached out to pet it. And James asked, confused, "What cat?" And then I, in that moment, knew that Chris was right. It was my Parkinson's.
I wasn't there when Paul was diagnosed. I was at a conference in Omaha, of all places. He was so upset that I could barely make out what he was saying on the phone. I think we knew deep down what the tremor in his hand meant, but having it confirmed, it just opened the floodgates, so to speak. And then we went through the normal stages of grief, met with the doctors, signed him up for clinical trials, and after a few years of ups and downs, we found ourselves at not a stasis exactly, but a new normal. You know, I'll help him get dressed and eat his meals. He's pretty good about getting around with his cane, but sometimes he needs an extra arm to hold. And when he goes out on his weekly lunch with the guys, I try to get a little me time in. You know, I'll go to get my hair done or go for a walk.
When you get diagnosed, they tell you that you might eventually start to see things that aren't there or confuse things that are there. Those Parkinson's books, there's this story about this woman who was talking to her houseplant because she thought that the leaves were green heads. She seemed so calm in the story, like it's perfectly natural to talk to a row of tiny green heads. Even after they told her it was a plant, she just went back to finish the conversation. It just seemed absurd to me.
Sometimes I'll think back to before the Parkinsons, the things that we could do, going out to eat without having to constantly remind the waitstaff to only fill his cup up halfway, or needing to take his sticky placemats out to a fancy restaurant, or how we'd go on hikes around the island. Not that we were doing Cocoa Head every weekend or anything, but we'd get out and enjoy the scenery whenever we wanted to. Not whenever his Parkinson's allows. But then he'll laugh at himself as he drops some food off of his fork, and I am reminded that he is still that same vibrant, warm, strong, handsome man that I fell in love with, and who's shared my bed for the last 38 years.
I even wondered if seeing things could be not a good thing, per se, but like fun. Like, would it be so bad to see my kids sitting at the dinner table chatting about their lives? Some of the stories that other patients had sounded fascinating, like seeing beautiful art in your home. And then I saw the cat, and I think about how lucky I was to have been in a place that was relatively safe. I was sitting. I didn't stab myself with my fork. I was with friends who know about my condition. I recognized that I was having a hallucination, and I could get help if I needed it. Like I said, lucky. But now I wonder what comes next. I know what comes next. Just like everything else with this disease, it's just going to keep getting worse.
He's still that vibrant, warm, strong, handsome man that I fell in love with, and who shared my bed for the last 38 years. And he's suffering. He's been suffering, and now things are just getting worse. It used to be tolerable when it was just the physical challenges, but now he's starting to fall more, and his mind is starting to go, and I don't know if I can do this.
I tried to get Eleanor to talk with me about the end. She hates it. You'd think a CPA would like all the paperwork that comes with power of attorneys and living wills and all the other stuff you have to sign off on to die. But she can't handle it. And that's the thing that, look, I worry about the tremors and now the hallucinations, and I'm worried that I might eventually be trapped in my own body and mind. But at this moment, the thing that's most upsetting to me is that I can't help her. I know that I've been a burden on her, especially since the kids left, and I just want her to be okay.
And I know that makes me sound like a horrible person. I know it, and don't try to convince me otherwise. Here I am. I'm supposed to be looking forward to retiring, and I am dreading it because it means that I'm just going to have to spend more time taking care of him. What kind of wife has those thoughts? And maybe I can't retire, not now, not with his Parkinson's getting bad, but Paul can retire. He's going to be forced to retire, more like, because he can't keep up at work anymore. But if he retires now, then how are we going to afford all of his bills?
Even though they're trying to force me out, I do still have some perks at the hotel. Maybe I should try to get us a nice staycation or something.
And I don't want to put him in a home. I can't imagine being without him, sleeping in an empty bed, but it's getting so much worse, and I'm so exhausted.
Maybe I should get her a staycation. You know, just let her hang out with her friends at the spa all day while she doesn't have to worry about helping me eat or get around the house. I could probably have the guys stay with me while she's out. Kind of be like living in a frat house again.
I'm exhausted. But he is suffering. I just know that I can't do this alone anymore.
We have a lot of hard decisions to make soon. But not today. There's a lot of living to do between now and then.
Paul? Paul? We need help. I need help.
Scene. Ladies and gentlemen, a nice round of applause. Matthew Kelty, Christine Lambourne.
Dang.
I'd like you to both to introduce yourselves and say a little bit about yourself.
Of course.
Go ahead.
Oh, thank you. Hi everyone. My name's Christine. I am an actress and educator here in Hawaii. I graduated from UH Manoa with a Master of Fine Arts degree in theater performance, and I'm just so honored to be here with you all today to have a breakthrough for, starting a difficult conversation. So thank you for having us.
Hi. Hi, I'm Matthew Kelty. I have an MFA in playwriting and acting from the New School in New York, and I'm currently a PhD student in Asian performance at the University of Hawaii at Manoa, and the artistic director of the Oahu Fringe Festival. And just want to thank all of you for allowing us to be here today and for being so supportive. Thank you so much.
One more time, ladies and gentlemen, a nice round of applause for Matthew Kelty, Christine Lambourne, director Alex Munro.
All right.
So what we're going to do is we're going to bring our panelists back up onto the stage, and I'm going to put them over here.
Thanks, Billy, for getting us going again. And thanks to the actors and director for another great skit. Hallucinations refer to seeing or hearing things that aren't there. Delusions refer to believing things that are not true. The presence of hallucinations and delusions is technically known as psychosis. These symptoms may range from mild to severe. So, kind of start off like I did last time for Dr. Bruno. How common are hallucinations and delusions in Parkinson patients that you see?
No switch.
Yes, thank you so much. Again, a riveting performance and amazing script that is very realistic. Even before just talking about how common it is, I just want to speak medically a little bit about hallucination for the origin of hallucination. I think the hallucination and the delusions could be a little complicated in its origin. So as Parkinson progress, there might be some degeneration in parts of the brain that can contribute to hallucinations and paranoias, but also medication. Some of the medication that's used in Parkinson's disease, which increases dopamine level in the brain, can also bring about hallucination. And some medications are more common to cause hallucinations than others, but a lot of them can. So the incidence could be somewhat confusing, but again, I'm not just bringing this number 50 all the time, but up to 50% of people can at some point experience hallucination. It's a little more common later in the disease, but it could also happen earlier depending on the medication. Sometimes it goes away with decreasing the medication, but sometimes even if you reduce the medication or eliminate it, it could still be there. So it's a very complicated topic. But it's good to, I think in the past, as with the other Skit, in the past, we tend to, as a neurologist, we tend to not bring it or ask until the patient or family brought it up, but we're now increasingly recognizing that very mild form of hallucination, just seeing shadows or little, shapes could be very common. So we're trying to bring the awareness and effort to bring it about.
Thank you. Again, I understand there's different types of hallucinations. We've been talking visual hallucinations, but Dr. Spira, could you talk about some of the other types of hallucinations there are?
Sure. I mean, as you mentioned, you read the definition. I thought that was very comprehensive. Thank you. There's visual hallucinations that can be as subtle, as the doctor said, as a shadow. What was that? Who was that? There could be someone sitting I think they're sitting over there. Is that a person? Why are they looking at me? So there can be suspicions. You can see something that actually might be there actually as a shadow, but then you interpret it as something that's not there, right? So it can go as extreme as actually seeing something, and usually this is if there's more advanced brain damage or if there's a lot of medication that's causing it. So in more rare cases or more advanced cases, you can actually see an actual person or thing there that's not there, that no one else can see. But that's more rare. Usually, as was suggested, it could just be like a shadow. It could be, this is the visual, and it's usually the interpretation that is confusing. You can also get very commonly auditory hallucinations. Again, a sound, was that a whisper? Why are they talking about me? Why are they gossiping? I don't like that. What are they saying? Again, it's kind of a blend between perhaps something that actually is heard and then your interpretation of what it could be. And then in more advanced stages, it could actually be voices that are external to me. Or in some extreme cases, it could be voices that are inside my head, but it's not my voice. They could be commanding me, actually, to do something. But again, that's more rare in this kind of situation. So that whole continuum. The difficulty with such hallucinations or delusions, as was pointed out by Jerry, belief about something, you get a fixated, obsessive belief about something that no one else thinks is actually happening. My wife is cheating on me. Why are you cheating on me? She's with me all the time, but she's cheating with me. Cheating with the physical therapist. She's cheating with the milkman, when there used to be a milkman. So things that, clearly cannot be the case, but I get obsessive and I believe it. Well, with hallucinations, there's a kind of obsessive belief about it too, and this is what's so difficult. It didn't come through so much in the skit, but in reality what happens is it's hard to try and convince the person that they're not having that delusion or hallucination because they really believe it. They actually see it. They see it like I'm seeing you. And you're telling me you're not there, or they're telling me you're not there. They're wrong. Why can't they see it? Or is there a conspiracy that they're trying to convince me that I don't see what I see, hear what I hear, know what I know? This is the insidious aspect of this problem. And sometimes it can be as simple as lowering the medication and it goes away. Sometimes you have to add a different medication to control it. But I'll tell you, just trying to convince the person or enter into the delusion with them is not the right way to go.
One of the interesting things I read talked about hallucination delusions of smell. And smell is, it's so nebulous to begin with. It's kind of, when do you know it's a hallucination or delusion? When do you know it's not real? Because at the beginning, you have some insight that says, yeah, you kind of recognize it's not real, but when does that stop and you start actually believing it?
That's the problem. And smell is particularly interesting with Parkinson's. Maybe you want to talk a little bit about that as a precursor or an early detection.
Yes, thank you. So in Parkinson's, it is known that the smell sensation you can start losing smell sensation with a degeneration of olfactory bulb, even before you start to have tremor. And that doesn't mean just because you lose smell that you're 100% going to get Parkinson's, because there are many reasons to lose smell. So I just want to clarify that just because you have decreased smell doesn't equal to Parkinson's. You could have COVID or something else. But in Parkinson's, the degeneration could potentially happen, so you could potentially lose smell. And the smell control area is very close to the emotional part of the brain as well. So I think you could also have hallucination where you start to smell. Anytime there's an absence of sensory input, like visual loss or hearing loss, the brain sometimes try to make up a little bit. So that could contribute to some hallucinations, delusions, and so the absence of smell can also later lead to some weird smell sensation.
And this is critical. This is kind of complementing the delusional hallucination. It's not quite the same, but this filling in, we have loss of hearing, and sometimes you get tinnitus or you get sensitivity. The brain compensates, like you were saying, in smell, but it happens with memory loss too. As people start progressing in normal aging or dementia from any cause, people start filling in with their brains, and often will start filling in ways that other people don't understand why they're telling that story to themselves. So it's not quite delusion or hallucination, it's kind of normal higher brain processes, but it can look very confusing to people. Like, no, that didn't happen. Why did you think that happened?
So of course, I love Dr. Bruno's comment that it can be the disease, it can be the medications. But the question I ask, is it causing distress? Does it impact comfort or safety? We may not be able to get our patients to the point where they don't have any hallucinations. We want to try to look for non-drug methods to treat, or adjusting drugs rather than just adding drugs. I try to teach my families there really is no reason to try to convince your loved one that the hallucination is not real. It is to them. So this confrontation, no it's not, yes it is, no it's not there, yes it is, it doesn't work, it doesn't help. And that's hard. We're used to being exacting and correct. And instead, are these hallucinations making them anxious, fearful? Are they grabbing knives from the kitchen? Then we really need to have to do something, right? Another situation I face in hallucinations is if someone lives in congregate care, like an assisted living or an adult residential care home, is it freaking out the others, the other residents? Because we have to protect their wellness as well. And these events with hallucinations and delusions, they can threaten the ability for a person to live where they're living. Huge. The stakes are high.
Yeah, very interesting, very great discussion. We have a question from Zoom land. So, Bill, if you'll relay that for us.
Thank you very much, Jerry. Here we go. I opted for DBS and am not taking levodopa. Am I less likely to experience hallucinations?
Yes, thank you so much for that question. So the L-DOPA, increasing dopamine level in the brain tends to exacerbate hallucination. So one of the reasons sometimes we opt for deep brain stimulation is decreasing side effect, not just hallucination, but any L-DOPA is a wonderful medication, but sometimes there is a limitation with side effect as well as sometimes motor complication wearing off. So sometimes that is the reason we consider deep brain stimulation, not only, but that is one of the reasons. So in general, opting for deep brain stimulation might reduce the chance of having hallucination, but would not eliminate. I have, unfortunately, patients with DBS who still have hallucinations. But in general, deep brain stimulation tends to be a little bit of a lesser cause of hallucination compared to L-DOPA.
Thank you much. Do we have any questions from the audience here? Anybody? A lot of people think about it. A couple years ago, when I was doing a presentation to a support group, one of the interesting things happened was there was a woman her mother had Parkinson's and she was experiencing severe delusions where she would keep knives and a machete under her pillow. And so when they went to, when they go to wake her up, they would have to stand across the room and kind of wake her up. And they would, when she was in the shower or going to the bathroom, they would try to take those weapons away. But she would always find another one because they lived in the country. And the question is, for them, for her is, what can I do? What can I do? They were getting to the point where they were almost deathly afraid of being around her because the hallucinations, delusions were so real.
Yes, and they should be afraid of being around her if she has knives and machetes, because the hallucinations are real to her, and she could be acting. I just interviewed a patient at OCCC, a patient, I'm a doctor, so I think, an inmate at OCCC who killed his fiancée because he was convinced she was trying to kill him, and she wasn't, it turns out, but because he was schizophrenic and having these hallucinations, he really believed it and had to act on it. That's rare. Most people don't really try and hurt you. It's more conspiracies and concerns and worries, like why are you cheating on me, or why are you all against me, or something. And part of it too is my loss of self-control, my loss of independence. Just with normal aging, people are going to complain about this too. I don't want to have people take care of me even though I need people to take care of me. There's natural existential concerns here. But then when you get a little disinhibited, the dopamine's a little too high or whatever happens, the brain's not operating, the front of the brain's maybe not operating as clearly as it used to. Whatever little feelings become big and externalized and believed. So you don't want to, I really found this out the hard way, but it's a truism in my field. Don't enter into the delusion with them. Don't support it. Don't play along with them. It doesn't help. What you can do is say, I know you seem very distressed about your concerns. You seem very concerned, very distressed, very uncomfortable. Is there some way I can help you relax? Let's maybe take some medicine, go see the doctor to help you feel more comfortable about this. But absolutely, if there's any weapons around, take them away. That's not good in this kind of scenario. Whatever it takes, do not have weapons available. They could hurt themselves, and it's not their fault.
I guess we all have our guns and knife stories. I had an 86-year-old lady who, yes, was getting the knives, yes, thought people were harming her, and she attacked the driver of the car, her son. There was a special needs daughter at home. She was threatened. And it's so hard to get these people care. I sent them to the emergency room, and because hallucinations are intermittent, she was not admitted. Oh, she's 86, she's fine. I couldn't believe it. She even had a psychiatrist on her case. And I called the psychiatrist and said, I can't believe this, that they would send her home. So it's very hard to get help because they're intermittent, and it may be an 86-year-old little old lady. Well, that's ridiculous. It's a little old lady. But they're so real and can be so dangerous.
And they can pull it together for a few minutes. When they have to, when the environment changes, when they orient, they can usually organize it, and then the police or the ER, even a psychiatrist that should know better, can say, well, there's no justification for me holding them then, and they send them home. But documentation helps, video helps, other people's comments help. That will help the ER and the police and the psychiatrist justify treating them.
So I think what I'm really hearing is the single most important thing is take some action. You just can't let these conditions just kind of run their own course. You need something that needs to be done.
They usually are able to be helped to some extent.
Yeah, I'm going to go back to Billy for the next question.
Test 1, 2. Thank you very much. My last visit with my doctor, he informed me that I'm entering the second stage of Parkinson's, 6 years after diagnosis. Is it in the second stage that hallucinations start, or is it later stages?
One of my fascinations with Parkinson's disease is the symptoms can arise at any point. There's not a specific organized order. And maybe Dr. Bruno can speak to that.
Yes, thank you so much. I actually get asked a lot what stage I am in. And it's hard to answer that question because there are stages, HONER stages, which is based more on research, and I don't find it as practical. We can categorize them in stages based on motor function. But as we are discussing right now, non-motor function, no motor symptoms, including hallucinations, but depression, anxiety, as we talked earlier, cognitive or autonomic, constipation, all of these could be quite disabling. So there's a general idea that some symptoms are a little bit earlier than later, and like smell is a little bit earlier. Mild cognitive processing is probably a little more earlier than later fulminant hallucination or dementia severe. But as we discussed, you can have hallucination quite early from side effect of medication, depending on your fatigue level, sleep level. As we all know, symptoms can fluctuate. So again, it goes back to not everybody have exact same symptoms. It doesn't always come linear, but by taking care of our brain health, rest, exercise, all those things can definitely help at any stage.
Great, thanks. Now let me check back in with the audience. Anybody in the audience have a question? Mr. Tommy.
Well, one thing that I've learned when I did my degree in psychology is to have a person take and delineate clearly what they see in the illusion. In other words, is the cat orange? Is the cat gray? Is the cat black? And how big is the cat? And looking at it from that vantage point, you can get them to see more clearly what they see. I mean, instead of just denying they're seeing it, they can actually classify and categorize the size and the weight of the cat or whatever it is that they see. So, do you have any wisdom about that?
Well, it plays partly maybe early on, or if there's not too cognitive impairment, some have insight that this is not real. Wait a minute, a cat on the table? But later in the disease, they may not. So it comes back to you, don't feed the delusion. So it's hard to know when that can be the right approach or not.
But I like the way you're framing it, that if it's early on, if they have enough kind of separate cognitive reflective ability, then maybe you could challenge it a little bit. But at some point, I think it is not beneficial to do that because they think you're encouraging it and then they get excited about it and get more into it. So early on, that might be useful to challenge it.
I want to also comment on this, that I agree with both of the panelists that sometimes when we start discussing the detail of the symptoms or increased medicine, decreased medication, get a little bit confused. So what I like to do is step back and discuss what our goal is. What is the most realistic, best goal that we can have together as a team, as a patient, caregiver, and me. So as Dr. Borman said, it might not be 100% eliminating all hallucinations. That might not be possible. It might be safety. It might be addressing distress. So we have limited time in the office, but rather than going into like detail of the symptoms and dissecting it, we want to kind of step back. It's a very difficult situation, so we just kind of want to step back and focus a little bit on the bigger goals.
Great, thanks, Doc. Any other questions from the audience? If not, oh, here, one over here on the right side, please.
So, regarding the delusions, so sometimes, like what if they see ants, right? But there's no ants. How do you phrase it to them that, there's no ants over there, or?
I always go back to comfort and safety. And it's kind of like what Dr. Bruno said is, what is the goal? People want to be comfortable. They want to be safe. If there's hallucinations about ants, don't worry, we can take care of that. Don't worry, we'll support you and the ants won't win. Reassure them that they're okay. Don't engage the ants. Don't go reach for the raid, the raid spray. But get to the emotion. Are you afraid of this? We can help that fear. And how do we treat fear? Comfort, closeness, human contact. I'm always looking for non-drug therapy. We know it's important in Parkinson's because the medicines can have bad side effects. But part of my fascination and challenge in medicine is not only is the patient not following the textbook about when hallucinations happen or when that happens, the real truth is there isn't even a textbook. People are so unique. We really have to be able to think outside of the box. But, ants, like, well, let's wear long sleeves so they can't get your arms. You're safe in bed. We're going to pull up the covers. We have to think outside of the box.
Well, and something I like to do from you've probably all heard the term mindfulness meditation. I think that again, you don't want to encourage them about the neighbors gossiping about them or the ants crawling on them. But I often say, oh yes, you seem to be distressed about that, but even if they are whispering about you, so what? It doesn't need to bother you. Let them whisper I don't know that they are, but if they are, so what? Let that go. Learn to relax. Learn to be where you are, as comfortable in this moment as you can be. So let's learn to disengage from your worries, calm yourself. And then even if they were, that's their problem, not yours. Even if there are ants, so what? It's okay. It doesn't need to bother you.
Yes, I actually completely echo that, but I wanted to add one practical script. Sometimes this is what my husband does to me when I'm anxious or angry, is would you like a cookie? So distract them a little bit and just talk about something else. I mean, that doesn't always 100% work, but rather than saying, I think the answer to your question is, it doesn't really help to say there's no ants. That doesn't get you anywhere. So rather than going into that, ask about emotion or distract or talk about something else. So not agreeing that there is an ant, but also confronting, neither of those help.
I think we have a question over here to the right.
Aloha, my name is Norma Cobb, Senior Medicare Patrol Hawaii Director with the Department of Health, Executive Office on Aging. Mahalo, Mr. and Mrs. Jerry Boster, for all of this and all of the team who put this together. So my question is two-part. Number one, why were you turned on in this area of medicine? Number two, thinking outside the box. What is happening with Parkinson's as far as future trends and how we can kako and help people here in Hawaii.
Well, hold on the second part. I'm actually ask you to defer that to Dr. Ross. He's going to have a presentation on that after this one, and specifically addressing it. To the first part, I'll let the doctors go ahead and answer what turned you on to this field study.
Okay. I became a health and medical psychologist because I find that people who are facing life-threatening illness are the most real people I ever interact with. They have the ability to look at their life, as the skits showed, it's raw, it's critical. They have to say, what's my life about now? And I find that these individuals have the best opportunity to determine how they want to be going forward, within limits, within the physical limits available. But these people, more than any others, have the opportunity to say, how do I want to live the fullest life I can in the time I have left moving forward? And I just love to be a part of that.
I think it depends on what day it is, what I say draws me to this work. But the humanness, I think it's the miraculous thing of life. It's so different, it's so unique. Every person is different. I mean, look at siblings. You have maybe 3 children in the family, raised, bred of the same mom and dad, raised in the same household, and they're each so unique. So that uniqueness and the miracle of life, I love it. I love life. And certainly helping, it matters. Sometimes my specialty is asking questions that I don't have the answer to. They say in law that never ask a question that you don't know the answer to. But because we're trying to get at goals and values, like Dr. Spira mentioned, it's like, how do you want to spend the time you have left? What's important now? And these challenges of serious illness help us say, well, if I only have X amount of time, and sometimes the doctor's specific. I mean, in my work in hospice, it's like, what if you only have 6 months left? How do you want to spend it? Then let's make that happen. How can I support your goals? So it's different for each person. Each person is different. I just love how unique and miraculous life is.
Yes, it's hard to top both of those answers, and I completely agree, but I'm specializing in Parkinson's, so I just want to talk a little bit about what specifically Parkinson's drew me. So this was in medical school. I was rounding with my professor. I saw a very disabled Parkinson patient who could barely walk, and my professor threw a ball at him, which was very scary. Everybody gasped, but he caught it. And so the brain is an amazing organ, and in Parkinson's, I think we all know this, there is ability somewhere deep that you can still do things. And everybody with Parkinson's knows that some days are good, some days are bad. How can we bring about that goodness? There are good days. How could we, there's potential. It's slightly different from a different kind of disease where you're completely, you lose complete ability. Parkinson patients live a long time and able to function okay. So how can we bring about the best in various different ways? So I think that's what drew me to Parkinson's, and knowing, patients and families for a long time is very inspiring. I learned so much and make connections. So I think that's very inspiring to me.
Thanks very much for those very open and honest answers. I want to get back a little bit to our topic that we kind of started off with, because I came across a kind of a unique one. We've talked a lot about how people get distressed by the hallucinations and delusions and want to get them back to a comfort spot. But what about the kind of unique patient who doesn't seem concerned about having delusions or hallucinations? They're just like, So what do you do with them? Do you worry about them? Or do you just kind of let them go and enjoy their hallucinations? Go
Okay,
ahead.
okay, I'm going to answer this. Okay, so yes, delusions and hallucinations very common. So I think the first question we want to ask is how distressing it is. And if it's not as distressing to the patient and family, sometimes it is education that this happens. And if the family and the patient can't cope with it, we don't necessarily have to jump in with a knee-jerk reaction to put them on medication or freak out. So if they can deal with it, I think that's, as long as it's safe and not distressing, we may have to accept some degree of hallucinations.
Great, thanks. Go ahead, Pat. Dr. Borman.
Well, yeah, I'm sounding like a broken record, but it comes back to comfort and safety. If the person is comfortable who's having the hallucinations, what a blessing, they're not uncomfortable. But we have to provide the anticipatory guidance for their circle of care. This happens. If your loved one is not distressed and it's not dangerous, then you don't have to be distressed. You don't have to make an emergency of it.
Sometimes they can be beautiful. When my mother was in her last week or two of life, she was seeing her husband. She was seeing her father, her brother. She was having conversations. That was beautiful. People would come to me and say, "Oh, I'm so worried your mom is..." I said, "What's to worry? It's nice. She's connecting." So yes, if there's no problem, there's no problem, you know.
Great, thanks. Bill, I think you had another question from Zoom, or do you want me to go ahead and take that? No, I'll go ahead. I got you. The question was, please speak about REM disorders.
Okay, so REM sleep behavior disorder is slightly different from hallucination. When I ask people, do you have hallucination? Some people say in dreams, or people enact dreams, and that's slightly different from hallucination in terms of medical definition. But anyway, when we sleep, we go into different stage of sleep, from light to deep, and at the end of the sleep cycle, we have something called REM sleep behavior disorder. I'm getting confused. REM sleep behavior. Okay, so during REM sleep cycle, we dream. That's the time that we dream. And normally, we're paralyzed because we don't necessarily want to act out or dream. When we're in REM sleep, sometimes the dream feel pretty real because part of our brain is awake. So we're normally paralyzed. And in addition, a lot of our dreams are bad, actually. A lot of people say I have bad dreams, but the function of the dream and sleep is to reorganize our memory. So a lot of dream is bad and distressing. So normally we're paralyzed, but in REM sleep behavior disorder, which is very common in Parkinson, the paralysis is not complete. So what that means is naturally people start reacting to dream, start talking, start kicking, start punching their spouse maybe, try jump out of the bed, start running, sometimes trying to strangle the bed partners. So that is dream enactment.
Great, thank you very much.
And can I ask a question, follow up to that? Is it the case that persons with Parkinson's sometimes have an increased level or rate of prevalence of nightmares? Yeah, so the question, if they have more nightmares is a good, we don't 100% have data on this that I know of, but some of the medication can make the dream a little bit vivid. The dopamine is medication that we prescribe for Parkinson can make the dream a little more vivid, and already at baseline most dreams are bad in terms of ratio, so then they've experienced it more real. So I think that's general consensus.
So when I tell people their potential side effect of this medicine or illness could be that your dreams are more intense, they ask me, well, is that bad? And ever the optimist, well, if you dream of butterflies and rainbows, wouldn't that be wonderful if it was more intense? But if you're back in your military or dealing with things that are stressful and icky, then no, we want to try to address that.
And from a self-help standpoint, there are medicines that can help. The Seroquel used to be given. I don't know if it's still given for that, and other prazosin and things might be given. But even before medicines are attempted to try and help with that kind of thing, I try and train people in, for example, meditation, relaxation. If they practice meditation, relaxation every day, then when they wake up from a nightmare or some disturbance, they can say, that was a dream, that was not real, this is real, calm my body, focus my mind. The more people can practice self-soothing during the day on a regular basis, the more they can apply it when they need it.
Thanks for the answers. The one thing that I've heard a couple times recently is medications. So the question is, are there problems with interactions between the Parkinson's meds and the antipsychotics?
Yes, thank you so much for that question. So first of all, I want to say the list of medication is ever growing, so it's getting more and more complex. But in general, Parkinson medications tend to increase the dopamine, whereas antipsychotic tend to decrease the dopamine level. So there is some conflict, innate conflict. However, the level of dopamine blockade in antipsychotic is variable in different medication. So in general, we like to try to avoid antipsychotic or antiemetic if possible when you have Parkinson's disease. And that's why it's so important for you to, whenever you start new medication, we really want to know about that. Call us and let us know when you go to surgery, when you go to hospital. Those are all very important time. But anyway, so we generally, if possible, want to avoid antipsychotic, but at the same time, everybody's different. Sometimes we need to use antipsychotic. We try to use something like Seroquel, as Dr. Spira mentioned, which has a little bit lesser dopamine blockade. So in certain situations, we would have to, and again, this is overall if the benefit outweighed the risk. There's usually no perfect 100% solution. We want to just kind of balance the benefit and the risk and come up to a group solution that we can work on. And that could be also, we might not be able to come up with solution with just one change or one visit. It might take a little work and feedback.
Thanks.
So it's really important to coordinate with your neurologist, because some other generalists might not understand, like the antiemetics, or if you have some movement disorder, they might give you something to help with that, but it might not work well with the Parkinson's medicines.
So I'd like to participate in the answer that my colleagues have done very well in answering and say, can we do something non-pharmacologic to help? And I believe the answer is always yes. We can focus on the unique strengths of that human being. Who are you? What will help you cope? I can't assume to know that, but can we draw the strengths of this person out to help? No drugs. Focusing on relationships, okay? Love is the strongest medicine I know. And if we can strengthen relationships, we are social beings. We need human interaction. It helps people feel better. It's not a drug. It's pretty darn safe. Dr. Spear has mentioned several times the be here now. Focus on the now. We don't know or control all of the future, and we can't change the past. We have the now, and we want to be living while we're alive. Focus on planning does really help, but only planning what we can take care of. planning helps avoid chaos. We can plan our advance directive. We can plan wills and estates and trusts to make sure we're not leaving a burden. But we can't really plan how the disease is going to unfold. So let's move our focus to what we can do something about. I like your phrase, make our best choices. And one of the things that Dr. Bruno said, she said, well, Parkinson's is so variable. It is a roller coaster. And Jerry says it a lot too. You don't know what kind of day it's going to be. So how can we get through that? Because we're not going to get over it. That's the disease. It's going to be like that. I try to stay positive and I say, we know there are going to be bad days. But I don't say it that way. I say, fortunately, there's going to be some good days. Enjoy them. There will be some not so good days. That feels a lot different to the person suffering with Parkinson's disease than bad days. It's framing, language is so important. How we say it, the body language we use, what we avoid talking about, what we feel are the important topics. People need to be heard. People with illness need to be heard. Their story, their version of how this is going helps them cope. And I know and have experienced and wonder how adaptable human beings are. They really, you sit in your chair and think, I could never stand it if I had to use a walker. But then maybe with your illness, you need to use a walker to be safe. And suddenly you can. This, I can't, until you're there, you don't know. Listening is one of the most powerful and safe medicines that I have. I can listen. This is actually a big part of why I went into medicine. I realized people could tell me stuff and I could listen. And listening matters. It helps people get through challenge. Instead of obstacles of illness, we have challenges. How can we get through the challenge? So focus on getting through it.
Well, Dr. Borman, I see you jumped ahead to where I was going in final thoughts. So that just about wraps up pretty much this session. I really want to thank our subject matter expert panel for the phenomenal job and the responses you gave us today. Thank you so much for your time and efforts. With that, we're going to take a quick 15-minute personal break. So,
Ladies and gentlemen, one more time, a nice round of applause for Doctors Michiko Bruno, Jim Spira, Pat Borman.